and learning evaluation, methods for P-Core and quality improvement assessment. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Rebecca Roper, Director of the Practice-Based Research Network Initiative at the Agency for Healthcare Research and Quality, will introduce today's presenters. We will have a Q&A session with each presenter and a final Q&A with all presenters. At the end of the webinar, I will explain how to obtain your CME Certificate of Participation for this webinar. And dialing back in. Please note our presenters' disclosures on this slide. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time during the presentation, but we will only answer them during the Q&A session as time allows. I will now turn the presentation over to Ms. Roper.
Thank you very much, Christina. So thank you all for joining us on this, what is a nice summer's day in Washington, D.C. area. We're delighted to have a very strong team of methodological experts. First, we will hear from Dr. Michelle Dietrich, who is a statistical scientist for Berry Consultants and has expertise in adaptive clinical trial design and Bayesian approach to medical statistics. In addition to trial design, she has expertise in analysis reporting in the support of data monitoring committees, and she has also served as a member of a data monitoring committee. When this team of experts came to our attention, they did so via a group of PBRN working group called the Pragmatic Trials Working Group. And this webinar, you will be able to earn CE credit today, as Christina will explain. But we are also going to seek to allow this to be a continuing resource of not only knowledge but CE credit through the PBRN listserv. And as Christina said, they will send out PDF files of today's PowerPoint presentation after the end of the presentation. So we will start off with Dr. Dietrich, and we will turn it over to her. And she'll give about a 20-minute presentation, and then you'll have opportunities to query her about her content, and then we'll move on to our next presenter. Dr. Dietrich?
Okay, great. And I'm hoping that you can now see my slides.
They look wonderful.
Okay, great. Thank you very much. Okay, I just wanted to begin by thanking the organizers for the opportunity to speak with all of you today. I'm going to give you a taste of adaptive randomized clinical trials, a high-level overview on some different possibilities and some suggestions for as you design conduct and reporting. So we already talked about financial disclosures, so I'll move to slide 9. So patient-centered outcomes research. The goal is to make better treatment decisions by comparing commonly used treatments. And we do this by using randomized clinical trials to compare the benefit and risk. Now, it's common for the trial structure to remain fixed for the entire trial, but you may want to make changes to the trial while running to adapt the trial to actually improve the trial and the ability to answer the study question. So the original design was based upon assumptions and incomplete information. If you would have had the answers to all these, you would not have needed to run the trial. So when the design was created, it wasn't known what the treatment effects were, the magnitude of them. Possibly didn't know the control, the standard of care, the comparison treatment or treatment therapeutic regimen information. And you may not have known the populations where benefits may be seen. So based upon that, adaptive clinical trials allow for key trial characteristics to change during the trial, and these rules for these changes are spelled out before the trial starting. And I put before in caps because that's very important, the pre-specification. All this is decided on ahead of time before actually looking at the data from the ongoing trial. Some of these key trial characteristics are perhaps the fraction of patients assigned to a treatment, the total number of patients enrolled, the number of treatments compared in the trial, or the types of patients enrolled in the trial. And these changes are based upon the experiences of the patients already enrolled, so that the trial learns as it is running. We also commonly refer to this as driving with your eyes open. You don't open your eyes when you start your car and then close them and then open them again once you reach your destination. You actually keep them open the whole time. So in a sense, this is how we think of adaptive trials, is that we have our eyes open and we learn as the trial is running. So some of the things we may learn are that the treatment intervention does not work. If you're looking at multiple drug doses or multiple treatments, you may find that some are promising and some are not effective. You may find early on that treatment does work very well, and you may also find that certain populations do not benefit from the treatment. So some examples of adaptations that may be in adaptive clinical trials. This is not an exhaustive list. These are just some of the possibilities. There's possibilities for early stopping, in particular early stopping for futility. And this is something I encourage in all clinical trials if possible, because it allows patients that are enrolled to go to other studies to end their participation if you know that the treatment under investigation is futile. And it also keeps additional patients from being enrolled when you know that the investigational treatment is not working. And then there also is possibility of early stopping for success. If early on there is evidence of overwhelming success, there may be desire to stop the trial early and disseminate the information. There may be arm dropping or adding additional treatments or dropping ones that are not effective. Another adaptation is called adaptive randomization. And what this does is it changes the randomization ratio so that more subjects are randomized to more effective arms. So in particular, we're talking about outcome adaptive randomization in, let's say, a 3-arm trial. In a 6-trial, the randomization probabilities for each of those 3 arms would be 33%. In adaptive randomization, at some point during the trial, you would unbalance that randomization so that those probabilities would change so that they would be higher for the arms that are more effective, and thus more patients would be randomized to the arms that are more effective. And a 4th adaptation example is enrichment, and this is a situation where you would enroll more subjects in populations that seem to benefit from the treatment, and may also drop groups of subjects. So you're enriching the clinical trial with subjects that seem to be most, where the treatment seems to be most effective. So goals for adaptive clinical trials, they're usually designed in line with improving the patient outcomes, having better ethical balance, more effective treatment of the patients in the trial, and to complete the trial more rapidly and disseminate the information to perhaps change clinical practice. And the key point is that later patients in the trial may benefit from the experiences of the earlier patients enrolled and treated. So I wanted to talk about some minimum standards, and this comes from a document that we created in response to a request from PCORI. These are minimum standards for the design, conduct, and reporting of adaptive clinical trials. And so the end of this slide presentation has a link to this paper, and there's much more detail. It's a long paper, but I'm just going to kind of touch on the minimum standards to give you a taste of what we think these are. The key standard is explicit prospective specification of the planned adaptations in primary analysis. The adaptations need to be specified ahead of time, and they need to be very clear so it is known exactly what will happen at each of the interim analyses. Prospective is the key here, so this is not an ad hoc kind of design where you look at the data and then decide what to do. Instead, this is something that's decided on before a single patient is enrolled, and all the details are specified in an adaptive design document that may be attached to the protocol. So this is the key standard. Adaptive clinical trials must be carefully constructed and tested before the trial starts. And so what we do is we run virtual trials on computers. We use a lot of simulation. So we create a set of virtual patients, and then we run them through the trial design to understand how that design would perform. And we do this many times to make sure that the design is calibrated and designed to answer our questions the best way possible. and that we understand exactly how it's going to perform and what's going to happen in scenarios for the different adaptations. Key stakeholders should consider the strengths and weaknesses before the trial is run. And what I mean by key stakeholders, the Institutional Review Board, the IRBs, other researchers, patients and representatives, or members of the community from which the patients will be recruited. They should consider the strengths and weaknesses of the trial before it's run. Another big standard is logistics and resources necessary to run the trial and implement the adaptations. So we're using the information as it comes in to make changes to design. Therefore, you have to make sure that the information comes in a timely manner and is usable to perform the analyses. So it's very important to consider that all these logistics, that the infrastructure is in place, that you can get the information in a timely manner, and that the analyses are set up to run quickly because there shouldn't be any pauses in the trial to run the adaptations. So this is a big step and varies from design to design as far as the complexity of the trial being run. Another big standard is to think about any possible favoritism or bias that may occur and do the best to eliminate these situations. So in these randomized trials, often they're blinded if possible, both the subject in the trial and the clinician treating the subject. And so we've been talking about adaptations where we actually look at the data and change the design based on what is happening in the trial. Now, those that are blinded and involved in the day-to-day conduct of the trial and that don't get to see this information should remain blinded and should not know these details. So it needs to be considered how best to keep them blinded and keep them separate from these analyses. And also after the analyses are conducted and adaptations are performed, careful consideration needs to be taken as far as what sort of information is disseminated to limit the knowledge of what happened at these adaptations the trial is going on. Because by knowing the results of the analysis of the unblinded data, there could be a potential for favoritism in recruitment and selection of the patients included in the trial, or possibly how they are treated. There could be slight changes. And so this is very careful to think about these things and do the best to eliminate the situations as much as possible. It's also important to form a committee or group to supervise the trial and make sure it's run as planned. I stress the need for prospective planning, and then the next key is to make sure it's run exactly according to the plan. So if someone needs a group, small group, this is an extensive large group that needs to be available to be monitoring the trial and make sure that things go as planned ahead of time. And then, of course, when you're done, there's many more pieces with the design, so full details need to be reported in the main clinical trial document to understand the design and understand what happened at each of the adaptations. So I wanted to end with going through an example, and this is an example of an adaptive randomized phase 3 comparative effectiveness trial called ESET. It's established, the trial name is the Status Epilepticus Treatment Trial. This trial is not yet enrolling. I checked on clinicaltrials.gov this morning. But there is a paper, again, referenced at the end of the Journal of Clinical Epidemiology that gives many, many details on the design and the design process for this trial. And it's a good example of an adaptive comparative effectiveness trial. So these are patients with established status epilepticus who have failed benzodiazepines. And the design of this trial was part of the ADAPT-IT project, which was looking at accelerating promising trials in the treatment, part of adaptive design, accelerating promising trials in the treatment, which was a collaborative effort supported both by the NIH and the FDA. So the goal of the trial is to identify the most effective and or least effective treatment from 3 common second-line therapies for status epilepticus within an emergency department setting. Going to slide 19, the primary outcome is clinical cessation of status epilepticus within 20 minutes from start of infusion without recurrent seizures, life-threatening hypertension, or cardiac arrhythmia within an hour. So there's this well-defined primary outcome, kind of hitting back to the minimum standards I talked about earlier. We're going to have a maximum sample size of 720 unique patients. I say unique patients because patients may have had multiple episodes of seizures and they're only going to use the first episode. And then there's a minimum sample of 400 patients. At least 400 patients will be enrolled and participate in this trial, and that'll be the minimum amount of information that they have. The adaptive components in the trial is we have the randomization probabilities are updated during the trial so that the proportion of patients randomized to better treatments is increased. So this is that adaptive randomization we talked about earlier, the outcome adaptive randomization. And so instead of starting with 3 arms and a 33% probability, as they go along, they will look at the effectiveness based upon that primary outcome that we find on the previous page, see which arms are doing better, and increase the probability of randomization for the arms that are doing better. If they're all about equal, they stay all about equal. The second main adaptive component is they will have interim analyses allowing for early stopping for success or early stopping for futility. So how it's going to run. They're initially going to randomize 100 subjects on each arm. So no adaptations are going to be performed in 300 subjects. The 100 subjects will be randomized, will be treated, and they will have that outcome information. And then they're going to adjust the randomization probabilities to favor the more successful arm. And then these probabilities are going to be updated again after every 100 patients randomized. They also consider what would happen if, for a particular arm, the randomization probability drops less than 5%. So this arm was really not doing well, and the probability is very low. So when we reach a threshold of less than 5%, they will actually suspend randomization to that arm. They're going to have this interim monitoring for the early stopping for success or futility. And when designing the trial, after looking at multiple options, they decided it was best to begin that after 400 patients have been randomized. So it can't stop with 400 patients. And the criteria for when they will stop is pre-specified. They're very detailed. I don't have time to go into the all the details of the criteria here, but it's in a paper. But success and futility is well defined, and the threshold from when where it may stop is very detailed and specified, and in the paper was all decided upon before looking at any data or before enrolling in a subject. And so after these interim analyses, if the trial continues, they're going to repeat these interim analyses for early stopping after every 100 patients randomized. Again, so the paper gives numerous details not only on the design, but the design creation process. So they determined key trial characteristics via simulation. So these are those virtual patients that they simulated, and then they looked at different possibilities in design and looked at the type 1 error, the power, the average sample size, which are the key trial characteristics. And they optimized those details to make sure the key trial characteristics were scientifically sound. So this wasn't looking at 400 subjects as the starting point for interim analyses for stopping for success and futility. That wasn't something that was just pulled out of the air. That was multiple iterations of the design, and they found that that time point best suited their goals for multiple considerations and best answered their study questions. The adaptive design was compared to a fixed design, and this is a very important detail too. Adaptive designs are not a general solution for all questions. They fit very well in many cases, but there are some situations where adaptive designs are not appropriate. So when you're considering adaptive designs, it's important to compare them to fixed designs. And what I mean by fixed designs, this is the standard kind of design where all subjects are randomized, nothing changes, the data is not looked at, and nothing is evaluated with the data until the end of the trial. So it's kind of the common basic situation. So it's very important to compare the two to make sure the additional complexities in adaptive design gives adequate gain, and to make sure it's applicable at all. A few conclusions, and I should say conclusions with the design. They found from simulating the trial and from examining the trial characteristics that if there's a situation where one of the 3 treatments is superior to the other two, the adaptive trial has higher power to detect that superiority and has a lower expected sample size, a lower average sample size than the standard fixed design. And that was a very important conclusion for them. And then they also looked at the situation if all 3 treatments were equal, what would the adaptive design, how would it compare to the fixed design? And they found that it had slightly larger sample size in the fixed trial. And in conclusion, they determined that the risk of a slightly larger trial was worth the benefit of the adaptive situation where they would have higher power and low average sample size in the situation where one treatment was superior to the other. So the idea of comparing the fixed to the adaptive design. Logistical considerations is a big situation here and with any adaptive trial. This is a trial that had a waiver of informed consent. It was in an emergency department setting. and doesn't have voice or internet randomization process. So they had to think about how they would update the randomization probabilities with the adaptive randomization. So what they do is they have 3 boxes with the IV study drug at each site, and the caregivers are instructed to use the top box labeled Use Next. And when they change the randomization probabilities after every 100 subjects, these boxes are reordered so that it follows this new randomization probability sequence. Now, thinking about that, it chose the design characteristics of these logistics in mind. For example, how often they wanted to update the randomization probabilities, because they wanted to make sure it was feasible. They didn't want to constantly be struggling with reordering these boxes too often where it would not be feasible. And after discussion and simulation and considering that this is how they decided on the 100-patient sequence. On slide 26, in this situation, this response adaptive randomization was feasible because the outcome was quickly observed. We had everything observed within an hour. This doesn't work with all outcomes in studies. You may have studies where the outcome is a year, observed a year after randomization. And that may be a situation where the timing may be too long to actually have the outcome information in to update the randomization probabilities. So this is another situation where you need to make sure that the adaptation fits the study question and can be implemented. Another thing they did, which is the minimum standard and making sure the logistics were possible, is they estimated accrual rate. And the accrual was not too fast, so it allowed time for the adaptations to occur. They wanted to update randomization probabilities and have interim analyses for early stopping, but they needed to make sure that not everyone was going to be randomized before this could be done. If everyone, maximum sample size, would be randomized in 2 months, they wouldn't have had time to do any adaptation. They needed to really think about what accrual was going to be in this situation. And then they also carefully considered the trial infrastructure to ensure the ability to implement the trial. And they did have a solid infrastructure to make sure the information could come in and be analyzed to implement these adaptations. So in summary, I gave a high-level overview here. I didn't give any statistical details. The statistical considerations are very important with these type of trials, and there are many things that need to be considered as far as the underpinnings of the statistical details. Didn't go through that here, but please note that that is a big part of these designs. But in general, adaptive trials do allow prospectively planning changes to the trial based on incoming information. They may help shorten the trial length or drug development process if you're looking at drug development, but they may also shorten the trial length in comparative effectiveness settings. They may lead to a larger number of patients in the trial receiving more effective treatment. And they may lead to better treatment of future patients having a disease or condition in the trial. And then this last slide that I'll wrap up with is just the 2 references. The link to the PCORI reference has this extensive literature review. So there are many more references in there if you want more detail. And then the example from the ESET trial. And I think with that, I will stop and be happy to take questions.
Oh, thank you very much. So we do have a few questions. One of which is there a particular software system that you would recommend in order to create the virtual simulated adaptations and design of the interim analysis and the rules of next steps that would be worked out before the trial is begun?
Sure. There are many different ways this can be done. Each adaptive clinical trial is unique to itself, so it really does depend on the trial. There are some software packages that allow for different types of adaptive designs and allow for simulation. I'm not recommending any over one over another. The ones that I know of, and please do not consider this an exhaustive list, there is a FACS software that is developed by Barry Consultants. There also is EAST, which is developed by Cytel. I believe there also is maybe some software called PADPlan. But again, please don't consider it exhaustive, and I'm not recommending one over another. Everything really depends on your study question. And I can tell you that in the ESET trial, for example, that was based upon computer code written for the trial, and it was simulated in the software package R, which is a freeware that is available. So every situation is unique, and statisticians can simulate it based upon their own coding. And then there are some software packages that allow
to be used for all their different types of design and to allow for the simulation.
Okay, thank you. And I had a question with respect to the traditional RCT and the intention to treat. Because you may be adjusting to which arm the patients may be overrepresented in subsequent phases, do you do some type of analysis on any differential in different arms with respect to the actual care provided versus the intended treatment?
Sure. We usually follow a strict ITT definition, and I believe that's also stated in the ESET paper, where subjects are considered in the groups they were randomized regardless of the treatment given, because usually this is thought of as a treatment strategy. So if for some reason they weren't able to be given the treatment to which they were randomized, that is important information. They still should be considered in the treatment group to which they were randomized. There could be possible situations where this may differ, but in general, we always start by following the intent to treat approach and follow and stick to that with all possible and as much as possible.
Okay, and I was just wondering, when I listened to your presentation, initially you seemed to be very open that the impact could be positive or negative in these different arms with not a definitive presumption of effect. So, of course, when you design the study, you're testing for a certain, to see if there's some differences. Do you tend to have two-tailed tests in all of the adaptive trial designs rather than having a one-tailed test of impact?
Generally, lots of things are one-tailed because you're usually looking for superiority, but there may be situations where just showing a difference is important. The example is kind of unique because they were looking at ordering them. So not only were they interested in superiority, one being better than another, but they're also interested in ordering, maybe finding out which one was least effective. But often when we're comparing things, I know statistically two-tailed tests are often used, but I tend to think back really to the question, and if the question is really, is one better than another, I'll use a one-tailed test.
Okay, great. Well, if you can stay with us, Dr. Dietrich, while we have the other presenters, and we'll open up the forum, and after they present and question, we'd love to chat with you some more.
Absolutely. Thank you very much for the opportunity.
Okay, great. So our next two presenters are one's hailing us from outside of Dallas, and Dr. Balasubramanian is assistant professor in the Department of Epidemiology in the University of Texas. And she focuses on problems in achieving optimal health care quality in primary care and the intersection of primary care, specialty care, and public health. And that's plenty for her career. And she has distinguished herself in her work on mixed methods and integrates her epidemiological methods expertise with qualitative research methods to compare effectiveness of quality improvement initiatives in primary care on process and outcome measures. And she is very much involved in the next generation of clinician researchers in the dual degree program for MD MPH programs. So we welcome her, and she will be co-presenting with Dr. Deb Cohen, who is from a further west in Oregon Health Science and University. Dr. Cohen has spent more than a decade studying primary care practices with a focus on clinician-patient communication, practice change and improvement in health information technology use, and has expertise in a range of qualitative and mixed methods approaches. So I will give the microphone over to those two doctors. One thing to reflect upon about our three presenters today is that they can make statistics both resonate with us and are very adept at fielding questions and helping us see the methods to go forward. So with that, I will turn it over. Ladies?
Okay. Hi, everybody. I'm Vijay Balasubramanian. Thank you really for spending your lunch hour today with us. Dr. Cohen and I are going to present an evaluation approach that we call the learning evaluation. And we have used principles of this approach to evaluate effectiveness of two national practice change initiatives. One called Prescription for Health that was focused on integrating health behavioral counseling in primary care, and the other that was focused on integrating primary care and behavioral health care called Advancing Care Together. We have also adapted and scaled up this learning evaluation approach for a third initiative that is currently underway called Evidence Now. Dr. Cohen will get us started by presenting the case for why the learning evaluation design is needed and under what scenarios it is particularly useful, and describing the foundational principles that are at the heart of this design. I will then follow and use the Advancing Care Together project to illustrate how we operationalized those principles to evaluate that multi-site initiative. So with that, Debbie, I'm going to hand over to you.
Okay, and so Bijal, thank you, Bijal, and thank you for having us. This is really an interesting and exciting series of presentations. It was fun to listen to the first one. So when we talk about learning evaluation, we're talking about studying changes that we think live at the intersection between quality improvement and implementation research. So we're thinking about evaluating interventions that are implemented across multiple healthcare organizations and finding a way to study those. So typically when we think about quality improvement research, we think about quality improvement in a single setting. And that work may or may not be evaluated in a way that those lessons can be shared with others who may be working on the same kind of change in their own setting. When we think about implementation research, we think about studying changes in more than one setting, but we may or may not have the methods to appreciate what's going on in a single setting. And we're trying to blend those two things in this approach that we call learning evaluation. Do you mind forwarding that slide, Bijal?
Sure.
So this method emerged, I think, out of a need that we started to see manifesting in the primary healthcare system in the United States. I don't think any of you will be surprised that primary healthcare and primary care practices have been in a period of rapid and continual change, and part of that has been stimulated by state and national demonstration projects that are focused both on changing practice, first and foremost, in the context of delivering usual care, and also trying to learn from those demonstration or quality improvement efforts. There are many across the U.S. that focus on the patient-centered medical home. We've been involved in some that focus on integrated care. And there's a unique opportunity to learn from these initiatives, but we have to adapt our methods a little bit to be able to do that, because learning from these initiatives poses some methodological challenges. So a couple of the methodological challenges that we'd like to highlight for you have to do with the context in which quality improvement efforts are implemented. So these are contexts that are continually changing. When a practice is approached about making an improvement, lots of things are changing at the same time, and sometimes it becomes very hard to make sense out of outcomes. This can happen, and Bijal may give some examples of this from Advancing Care Together. This can happen with a practice that's trying to bring a new behavioral health clinician into their practice, and as they start that work, sometimes they get additional payments or additional grant funds to expand that effort or to add a different element to that effort that might focus on management of depression and diabetes. And all of those things are sort of happening in real time, because this is how practices really exist, and we have to figure out how to track those changes along with the ones that we were initially interested in. So what happens is that traditional experimental methods, which are guided by principles of randomization, strict inclusion and exclusion criteria, and tight internal validity, are very, very difficult to attain in these real-world settings. So we started to recognize in our work a need for innovative study designs that are both flexible and rigorous, have good internal validity, and help healthcare systems learn from their QI efforts and what sort of naturally emerges for practices sometimes as rapid change cycles, and to continually assess the implementation process, what's going on the ground, as well as assess what's happening in the context and what's happening with their performance over time. And the learning evaluation approach that we're going to tell you about tries to accomplish those needs. So there's two key aspects. The first is facilitating learning, and that's from these rapid change cycles that the practices are engaging in. And the second is figuring out a way to capture and understand the contextual and explanatory factors that are related to implementation and influencing what's happening during implementation, and also potentially shaping what's happening with outcomes. And the learning evaluation is designed to try to balance this need for flexibility within the system innovation, because they learn things and folks learn things as they go along, and context changes, along with the structure that's needed to support a rigorous evaluation. So we've depicted this in this model, and let me see if I can walk you through it. So each of the dotted boxes represents a healthcare organization. For the purposes of our conversation today, let's think of it as a primary care practice. And the circles represent the PDSA cycles that we observed in our work emerged sort of naturally in these practices that were pushed to try to make a change. They try something, they evaluate how it was going using different metrics for evaluation. Some might be their gut instincts, some might be more data-driven. And then they tweak what they do. What we overlaid on that, and that's indicated by the gray box, was we overlaid some common evaluation and measurement on top of that. So we worked with, and we'll talk about this a little bit more with ACT, we helped the practices build infrastructure for data collection. What happens a lot of times is, particularly with integrated care, you go into a practice and they actually don't have the infrastructure to collect the data that they may want to assess. We collected consistent qualitative data across all of the organizations, and we harmonized the quantitative data that we collected so that while we were not necessarily collecting the exact same thing from each practice, we were collecting measures that were quite similar. And what we would do is we would collect these data quarterly. You could do this at any interval, but we decided quarterly was the right way to do it to maximize the amount of information that we got and to minimize burden on our practices, and they would share it with us. And Bijal and her team would analyze it, and then we'd have what is designated in the square at a learning meeting. We'd share the data with them in a brief report, and we'd talk with them about it. And these were really important conversations, because these data were sometimes the performance data that these practices were looking at they hadn't looked at before. And there were really interesting surprises in this about how many patients they were reaching with their intervention and how they were doing. And that would sometimes push a practice into another quality improvement cycle. So we did this with multiple organizations with a harmonized set of data, and we did this over time. And you can see some organizations might only have 1 or 2 quality improvement cycles, and some might have multiple. And we were flexible with that. We allowed them, they figured out what it was they wanted to change and how they wanted to change it. We just provided the evaluation and performance information. So there were a few principles underlying the learning evaluation approach that I'm going to highlight for you here, and then Bijal's going to bring them to life for you with some examples. The first is that it was really important that we gathered data to describe the types of changes being made by the healthcare organization and how the changes were implemented and the evolution of the change process. So over time, we needed to understand what they were doing and how they were doing it and how that evolved over time. The second principle was to collect process and outcome data that are relevant to the healthcare organizations and to the research team. Generally, there's a sweet spot there between what practice members think is clinically relevant to be assessing in order to understand performance and what researchers think is also important to be assessing to understand outcomes. And our job in this type of evaluation approach is to find that sweet spot. The third principle is to assess context, to look at the multi-level contextual factors that can affect implementation, that can affect the process of doing this work, that can affect outcomes, and can affect transportability. And we tend to do that with qualitative methods. The fourth was to help the healthcare organizations, in this case primary care practices and community mental health centers, to apply the data that they were sharing with us to monitor the change process and to have them find reflective space to take a look at those data and to think about whether or not they want to make further improvements. And then the fifth is to operationalize those measures for each practice in a way that they're harmonized across organizations so that there's a common measurement and assessment strategy that is focused on this aim of generating transportable results, results that don't only speak to the findings of that single organization, but can be generalized to others. So the illustrative example that Bijal is going to walk you through is Advancing Care Together. ACT was a demonstration project that was funded by the Colorado Health Foundation. It took place in Colorado, and the purpose of ACT was to change practice. It was to transform the delivery of health care by helping primary care and community mental health centers implement models of integrated care in their settings. So there were 11 clinics, and they were implementing integration in various shapes and forms in their own clinics. 9 of these were primary care practices. 2 of them were community mental health centers. This was a program run by Larry Green and Maribel Cifuentes out of the University of Colorado. And the practices that were part of ACT varied on the evidence-based strategies that they implemented. They varied based on how they identified patients, whether or not they used a systematic approach for screening for primary care and behavioral health needs, using evidence-based tools. They varied in the extent to which they were single organizations or multiple organizations, and whether or not they shared a medical record for recording and sharing patient information. And they also varied on the extent to which they co-located primary care and behavioral health professionals in the same site. And our job was to look at and understand these variations, how they influenced implementation and care processes, and also how they influenced outcomes. So now I'm going to turn this over to Bijal.
Thanks, Debbie, for that overview. And I'm going to use ACT, and as you said, try to bring these principles to life. So as Debbie said, the ACT program included a purposefully selected sample of practices that represented various healthcare settings, ranging from small private primary care practices to federally qualified health system practices and HMO practices, and we were really interested in studying the variation. And the goal was to learn the most effective strategies to integrate care across these 11. So to do this, we first applied the first principle of the learning evaluation, which was focused on collecting extensive qualitative data to get a really rich understanding of the baseline or initial conditions at each practice. For example, through review of the site's grant applications to the Colorado Health Foundation and interviews with practice leaders, we gained an in-depth understanding of things like the prior experience a practice had either with integrating care or with other quality improvement initiatives. The community linkages that a practice might have to refer patients for counseling, the level of motivation that occurs across the practice team for the wholesale change that an initiative of this magnitude needs. And guided by these 4 research questions, we collected data and analyzed data in real time. And by doing this, we obtained a longitudinal view of the types of changes practices were making, how they were implementing these changes, and the factors that helped or hindered the change process. We collected key documents, as I mentioned, like grant proposals. We conducted direct observation at site visits that we did at the 11 practices once a year. We conducted interviews at the site visits as well as by phone with key practice stakeholders. And we had an online diary where practice members recorded their the challenges and successes during implementation in an online private diary room. And evaluators, us, we reviewed the diary entries regularly, discussed them, and responded to them to generate a conversation amongst the practice members implementing this change. One of the most useful things we did prior to practices beginning implementation was to ask them to develop an intervention process diagram, such as the one that's depicted here. And it depicts all the steps in their intervention, and the practices, the sites participating in the intervention, refined this diagram over time in collaboration with the researchers, with our team. What this diagram did was help identify key elements of the interventions at baseline, and it provided a framework to guide measurement, which I'll talk about a little bit more in just a minute. It helped identify practice members with critical roles on the ground to participate in the online diaries. So as you can imagine, there might be the front office staff that is involved in the screening process up here, and then behavioral health counselors or health coaches that are involved in the delivery of counseling and referral processes. So it helped us figure out who should participate in the online diary to get rich data on the implementation process. And it also provided us as a starting point for following how each practice's intervention evolved over time. What our team did then was synthesize these intervention diagrams, 11 of these across the practices, to glean and identify similarities and differences between them. And this process was key, in our opinion, to developing a common measurement framework across the practices. So through this process, we learned that all of the practices planned to use some sort of evidence-based tools. They may differ on which ones, but they were using, for example, either PHQ-9 to identify patients who may be depressed, a GAD-7 for anxiety, hemoglobin A1Cs for diabetics. And they use these tools to identify patients needing integrated care. And then what were all the referral strategies that also the practice used within or outside the practice to provide additional services to patients. So that gave us 2 common measures. One was the screening rate and the other was the referral rate. Developing this common measurement framework was essential for collecting and specifying the process and outcome data that helped us then establish effectiveness of these intervention strategies. Oops, sorry about that. In tandem with collecting the qualitative data to establish initial conditions, we also surveyed the practices to obtain descriptive data on their structure, function, and patient panel characteristics. Along with the qualitative data, these data provided us with information on contextual factors that were operational at baseline that may influence the implementation process. And one of the papers from this initiative used these practice and textual factors, the qualitative as well as the quantitative, and the implementation process data to delineate overarching organizing constructs that shape integrated practices. In addition to this practice descriptive data, the intervention process diagrams of each practice helped us tailor the collection of the process and outcome data across practices. We used 2 instruments to collect these data, and we developed these and tailored these for the practices. The first was a REACH reporter, which was used to assess patient reach of these integrated care interventions at each practice. The practice completed this reporter every 3 months, so we had multiple data points over the life of the intervention. It asked practices to provide numbers of patients seen during the 3-month period that met the practice's target population, which they specified. The numbers that were screened using the evidence-based tools that they specified. The number that screened positive, and finally the number of patients who received further integrated care. And this reporter also collected demographic distributions at these 3 levels of data that indicate here. So I want to make a point here of that Debbie tried to talk about in the principles just a second ago, that we asked practices to collect data that were relevant to them, and that were relevant, of course, to us as a research team. The second the second data collection instrument was a patient tracking sheet that practices used to collect patient-level data, either by querying their EHRs or through manual entry. One of the key findings related to this data collection process that emerged through this activity was that most practices, and even the ones that had some type of health information technology support, were actually not equipped to extract data on integrated care services that their patients might be getting. So several of them actually created new EHR templates, workflows around recording those data, or if they didn't have the capacity to do the EHR templates, still collected data using the tracking sheet we provided to track the receipt of integrated care services amongst their patients. So we operationalized Principle 3, which is about then assessing multi-level contextual factors, by making sure that we collected and analyzed the qualitative and quantitative data that I just described in the previous 2 principles in real time and in an iterative fashion, so that we were learning from what the practices were implementing, but then by learning across the 11 sites, we were also able to help practices accelerate their improvement process, which I'll tell you in just a minute in the next slide. In particular, the diary data allowed us to make sense of the intervention experience as it was unfolding, and to identify key events that occurred during implementation. An example of that was one practice had a lot of turnover among their behavioral health counselors for several reasons, and the diary data helped us track on a timeline the turnover. Another was that practice temporarily suspended screening because of too much demand on their integrated care services. So in parallel to the diary data being analyzed to map the implementation process, we also created run charts using the quarterly reach and tracking data that each practice was giving us to the evaluation team. As you know, run charts are a classic strategy for doing with QI. What we did then is mapped the timing of these implementation events identified through the diary data onto these run charts so that we could understand the ups and downs in patient reach and tracking and make sense of some of the variation we observed. So then to operationalize Principle 4, we compiled the run chart and implementation event data in an easy-to-review report and shared it with practice leaders every 3 months during those learning meetings that Debbie talked about. These meetings really helped practice members reflect on their experiences within that context of the reports that we provided and their performance, and then to discuss additional changes that they might want to make to their interventions. One of the things that made these meetings really useful to the evaluation team and to the implementers was that the evaluation team was able to bring lessons learned from other practices to facilitate the practice change that the practice that we were meeting with was doing. We of course recognize that some health systems already have this QI capacity available to them, but among this sample that was trying to integrate care of real-world practices, most did not have this capacity, and this process actually helped them accelerate the change process rather than wait till the end to see if the intervention that they were trying to implement improved outcomes or not. Finally, we used mixed methods, both qualitative and quantitative, and integrated them together to generate valid and rigorous findings. We did this by incorporating multiple features into the study design, because we didn't have randomization in this real-world study, to help reduce different biases that may be at play. So using multiple data points, quarterly data collection, rather than just a pre and a post, it helped us evaluate biases that might occur due to history or maturation. By providing the data back to the practices and then facilitating a discussion about them at learning meetings, it gave us an opportunity to member check the accuracy of the data, which is a qualitative method to that helps with validity. And it also helped us develop rapport with practices that actually was really important in harmonizing data across the organizations. Using these design features and the mixed methods, we conducted analyses that were focused on triangulating findings, again, to enhance rigor across multiple data sources, and to identify contextual factors that were associated with successful implementation and outcomes. We used cross-case comparative analyses, longitudinal growth models, and mixed models to analyze the data, and then we have a paper in process currently that's going to combine these qualitative and quantitative and analytic techniques together to present the effectiveness of these intervention strategies. The idea, one of the things we talked about was to generate transportable findings, and when this paper was published, we were still in the process of analyzing the data, and we have these papers now in press that are going to come out in an upcoming issue of the Journal of American Board of Family Medicine that really focus on identifying and characterizing practical and effective strategies to integrate primary care and behavioral health care that we hope are going to be useful to other practices planning to implement integrated care. And our papers are very geared towards those practical strategies and generating transportable findings. So there are some considerations that are helpful to keep in mind if one wishes to use the learning evaluation design. First, that these principles that we have described are foundational, and they can be readily adapted to different multi-site initiatives. We are using these same principles to evaluate a large initiative that includes 7 research teams and over 1,700 practices. So we've scaled up this learning evaluation to this new project that is implementing dissemination and implementation models to improve cardiovascular disease prevention care. Second, the learning evaluation has a strong emphasis on engagement and openness to learning, both on the part of the evaluation team as well as the participating practices or health systems. This aspect of the learning evaluation, I think, is crucial for its success. Third, as I showed in the ACT example, the evaluation team must share data regularly and often with the implementation teams. So it really requires the researchers to be flexible and nimble in quickly adapting their approach when the proposed innovations are modified to fit the local context, the practices, or the settings in which it's been implemented. Some of the healthcare organizations, and as it happened in ACT, may not be able to collect the data that they initially agreed to. The flexibility that is built into the learning evaluation actually allowed us to assist organizations to collect data by suggesting alternative ways gleaned from the other participating sites. So for example, in ACT, we learned how other sites were collecting data by creating EHR templates and workflows that helped the collection of data in sites that didn't have that capacity. Therefore, it enhances the data collection capacity, not just for the ACT innovation, for the ACT intervention, but for future initiatives. So it improves practice capacity. Finally, when feasible, we recommend including control practices into the design to add much more rigor to the findings generated from conducting such an evaluation. We recognize that that's not always possible, and that's exactly what happened in ACT. However, control practices will add more rigor. As a summary, the learning evaluation has some unique features that I wanted to highlight just a bit more. It blends quality improvement and implementation research methods such that the learning that happens across multiple organizations can facilitate continuous quality improvement. And the rigorous implementation research methods helps generate transportable lessons for other organizations seeking to make change so that we can accelerate the research translation pipeline. It blends evaluation theories, where it uses a realist evaluation that focuses on identifying contextual factors to explain mechanisms and outcomes, but then blends it with empowerment evaluation, which focuses on helping innovators improve their change initiatives by encouraging self-evaluation and reflection. It's the blending of these theories that really makes this learning evaluation unique in that it empowers the innovators to make change as well as identify contextual factors that may be at play. For ACT practices, the learning evaluation method informed quality improvement activities and developed the capacity for data collection and monitoring that we think helped accelerate the translation of research into practice. So in conclusion, this learning evaluation approach facilitates continuous learning, generates rigorous and transportable findings, and adds contextualized ongoing knowledge essential to rapidly advance implementation science. Finally, teamwork is at the heart of our learning evaluation approach, and this work was only possible because each and every member of our team made critical contributions to the larger effort. I would also like to express my deepest gratitude to everyone involved in the ACT program, especially the practices that were on the front lines of integrating care. Thank you, and we're really happy to take questions at this time.
Thank you very much. Please take time to post your questions, and we will have the doctors respond. With respect to the objective of having transportable findings, and you're quite active in your publication. In your publications, doctors, have you pursued a particular way of presenting findings so that they are transportable with the contextual nuance to a variety of different healthcare settings on what they would need to do to have similar impact in their own healthcare settings? How do you make the findings actionable in their transportability?
Yeah. So there are a few ways that we've done that. One is in the selection of the practices that participated in this initiative, where it was a purposeful selection of a wide variety of practices that varied on context, so that lessons learned can be generalizable. We also try to, the papers that are going to come out are also really focused on identifying the features and the context in which some of those features are applicable, so that a small primary care practice can make sense of the intervention strategy that might actually work for this. Our papers focus on identifying the context as well as the mechanism that has resulted in good outcomes. That's the realist evaluation perspective of it. Debbie, do you want to add something to that?
No, I think that's exactly right. I think in our publications we try to make sure that they're mixed methods, and that we make sure that there's stories about what happens in these practices so readers can grab onto them and hopefully see themselves in those examples.
Great, thank you. So early on there was a question posed with respect to, you were talking about the approach with respect to the qualitative collection of information, the diary approach, which can be fairly intensive for the folks in the practices. And then you gave some examples which were very helpful, but could you elaborate on some of the balance or the richness of folks in the qualitative diary, composing of a diary, and how to make that beneficial in their use of their time to do that?
Yeah. Debbie, do you want to take that? Debbie is our expert here.
Sure. So the first thing I would mention is that there is another paper about the diary that you can find at the Journal of Evaluation, and if you want, I can send that to folks. It's labor intensive for both the evaluation team and for the diary keepers. The thinking behind the online diary is that we're trying to understand implementation prospectively, and if we only do it if we only talk with folks or interact with folks every 6 months, there's going to be some mundane elements to the implementation process that are lost due to lack of recall. So we try to make the diary, we try to have multiple diary keepers from each practice or from each research team. Sometimes we use this at the research team level. And we try to choose people that have different perspectives, but all have their hands in on the ground work. And so the pressure of writing a journal entry doesn't fall on one person, and it doesn't feel overly onerous. We ask that folks post every 2 weeks, but they're not out there alone. When we first started thinking about this, we were also thinking about doing some other interacting through the web. And the way this was explained to me is you're hosting a cruise ship. You're the entertainment director, and you really need to be out there interacting with folks to engage them. So we are posting questions on the diaries to follow along with what's happening in their projects. And we ask questions that are hopefully engaging and interesting and pique folks' interest, that it's something that they want to write about. And that's one of the ways that I think we make what is could be perceived as an onerous task feel a little bit less onerous. They really have an interested partner who's interacting with them on the diaries. The other part of it, the way we accomplish that is we have, at least in Prescription for Health, but also in ACT, we had a group of people who were reading the diaries, somebody reading them every day, but a group who was reading and talking about them every week, so that we were posting really informed questions, and we were analyzing the data as it was coming in. The other piece of this that's a benefit, perhaps more for a research team than for a practice, is that in Prescription for Health, a lot of these teams weren't collecting this kind of information about implementation, but they did by posting on a diary, and that became a data source for their use as well. So that was a bit of an added benefit. Does that help?
I think you answered it very nicely. If the person who posed the original question has any concerns, I think they can let us know, but I thought it was a very thoughtful reflection. Since you've been refining this methodological approach, and you've had different very, very large-scale studies, can you just share with us, as in your strong storytelling capacity, some surprises that occurred that caused the approach in general to change?
Okay, it's a good question. Abby, I'm trying to think at the top of my head. I think one of the
occurred that changed our method?
Yes, that caused you the next time when you went forth with a larger scale study again about some of the issues that
I think I'd like to say that it didn't. There have been surprises. I mean, so for example, I think we have had situations where practice members or health system members were not as engaged with the diary as we would have expected or we would have wanted, and we've tried to adapt that to get the information we need through one-on-one calls or other kinds of ways to do that. I think that as I was saying in my presentation, these principles are really foundational, and that they can be adapted to the context in which we're studying. So when we study practices versus when the research teams are our study participants, that the method is adapted just a little bit more so that we can learn. But I think in essence the method doesn't really change, but we use the principles in a way to adapt to surprises as they come along.
Yeah. The only other thing I would add, Vijal, is I think that we have gotten more refined in our thinking about how to harmonize quantitative data. And I think we've gotten better at figuring out how to use the diaries to inform these the quantitative results and the way that we help projects reflect. That you're completely correct. The principles haven't changed, but in shifting from using this with a practice-based research team and prescription for health to using it with practices, the need to really bring together what we were learning qualitatively and quantitatively for them quarterly to review what was happening just manifested itself, I think, as being a bit more critical.
Yeah.
So, but I agree.
So we have a few more questions, and I just have to put on my glasses to read. So with respect to soliciting reflections from patients, how did some of the patients react? How did you mitigate some of their concerns? And what was the traditional relationship or the variety of relationships of the folks who were engaging with the patient, the reflection, in terms of the care of the patient?
Yeah. Do you want me to field that one, Bijal?
Sure.
So we have, I would say, patient voice has not been at the center of this methodology, and I would personally highlight that as a slight weakness. Let me tell you the two places where it does come in. So when we do site visits, we observe the practice, all aspects of the practice, and that includes observing patient visits, doing what we think of as patient pathways, where we follow patients through their care. And that's very enlightening. You get a very good understanding how, by watching how patients react to their care in a way that uses observational methods. And sometimes we get to chat with folks while we're waiting around to do that. But mostly it's about understanding the care delivery process. And that's one way that we accomplish this. And patients and clinicians are very open to that. We explain to them that we are not interested in all, really, in the patient's identity or any specifics. We're more interested in the care process. And we're very careful not to collect any identifying information. In ACT, we did layer on patient interviews to design, and what we did was we had a stratified sampling process where we used the tracking sheets that Bijal had created, and we tried to select practices that varied on key attributes that we thought were going to be important. Those who got different types of integrated care, who were in different types of practice, and we did our best to try to stratify a sample that way. Now, we had to rely on the practices to approach those patients. So we generated a list of, I believe it was a list of patient IDs that we had from the tracking sheet. And the practices approached those folks. And some of them agreed to talk with us and some of them didn't. And then we interviewed them. And those interviews were good. I mean, they provided us, integration is a funny thing. Sometimes people aren't really aware that they're receiving integrated care if it's done well, but there were also a number of people who could be very articulate about the role that their practice played in their well-being, and that was helpful, and folks were generally very happy to talk with us.
Great. So there's a statement that's been made in the questions with respect to IRB approval, but the examples that you have given have been research studies. That I think the first one you gave, there was an exemption because of the nature of the consent in the hospital. So you can correct me. So a plan for protection of human subjects is part of your preparation work, and what needs to be done depends on the type of information and the data collection and use. But for the most part, am I correct in the examples that you have given, you have had to receive IRB approval because you're comparing a treatment options. Is that correct?
This is Bijal. Yes, that's correct. We had IRB approval for the study. Our main participants for the study were practices and practice members. I think when we received patient-level data, those data were de-identified by the practice and sent to us. In the example that Debbie Debbie just provided about patient interviews, that process was a bit more complicated because the de-identified data that we received had to be re-identified by the practice themselves, and then they had to contact the patients to maintain the confidentiality. So we worked very closely with the practices and engaged with them to around even these kinds of IRB issues. But yes, definitely the project had IRB approval.
Excellent. Can I just ask, so you've had some wonderful publications coming online in JABFM. When do you anticipate publication?
September 9th.
September 9th, okay. September 9th.
That's
okay.
what I heard.
They're at the printing press. Okay, very good. Congratulations. Did you want to make any other statements of clarification or redirection to our audience?
No, I think we're really thankful for the opportunity to present our research.
Oh, you've been fabulous, and we'll let you know when the YouTube posting of this wonderful presentation is available, and hopefully it'll coincide with your wonderful publications on September 9th, which happens to be one of our next, and it will be our final PBRN Resource Center national webinar, which is about rapid cycle research, and we'll be sending out, if you ladies don't mind, we'll send you that document as well. It might be of interest to you to complement your method, the methodologies that you represent in this particular spectrum to others. So with that, I say thank you very much, and Christina will give you folks instructions how they can get CE credit for today's national webinar, and it's been delightful. Doctors, thank you very much.
Thank you.
Thank you, Rebecca. So very quickly, if you look on the slide, to obtain your CME Certificate of Participation for this webinar, please complete the online evaluation, which will pop up upon exiting. And then you can email us at pbrn@abtassoc.com to request a copy of your CME Certificate of Participation. Thank you so much, and I believe that ends today's webinar.